I wanted to kick it off with a question to Dr. Rodriguez, and I was hoping you could walk us through the utility of molecular residual disease testing in oncology.
Thank you, Olga, and welcome everybody. Thank you for joining us today, and thanks to the organizers for creating this wonderful platform. So the answer to Olga's question sets the stage for our presentation. So MRD assessment can and should begin as early as diagnosis. Lessons learned from retrospective and prospective studies assessing MRD both in breast and other cancers have yielded valuable information when testing at diagnosis, and we are seeing powerful prognostic information when looking at the quantification of baseline ctDNA. For example, in the recently presented initial results of Circulate Japan colon cancer clinical trial in ASCO last month. Now, second, neoadjuvant treatment response monitoring will allow for an MRD adaptive design where patients who have a clinical response and a deep molecular response can be selected for reduced intensification therapy, whereas patients with suboptimal molecular response can be identified for studies with escalation of treatment with novel agents, of which there are many in this disease, as previously presented by Gail from Genentech. So detection of MRD and molecular recurrence with surveillance monitoring is another application that will allow us to intercept disease recurrence molecularly prior to clinical recurrence and offer doctors and patients the opportunity to treat at lower tumor burden, thus increasing a second chance of cure for patients. And HER2 positive disease will greatly benefit from MRD assessment, not just in breast cancer, but others as well.
Thank you. And with all of this utility, with all these benefits, can you walk us through how the Signitera assay is designed?
Yeah, absolutely. So the approach of designing Signitera differentiates it from other liquid biopsy tests that may not take into account the genomic profile of the patient's tumor at the level of the whole exome. So knowing multiple patient-specific tumor mutations allows us for high depth of read when sequencing and thus achieve higher sensitivity. Now, the first part of the test process involves performing whole exome sequencing on the tumor tissue, as well as match normal DNA from each patient. And based on these results, we can identify the differences and create a molecular signature of tumor mutations that are unique to each patient's cancer. We look at all the somatic tumor-derived mutations and apply our proprietary algorithm to select the most important or the most clonal mutations or single nucleotide variants, and then custom design and manufacture for each patient a personalized multiplex PCR assay that's going to target the top 16 clonal mutations found in the tumor. Now, in the plasma, we use this personalized PCR assay to amplify the targets and then sequence at greater than 100,000 x depth of read to detect the presence or absence of the patient's tumor DNA in their blood. So the mean of the detected target then becomes the reported result as mean tumor molecules per milliliter. Essentially, Signitera becomes a patient-specific tumor marker that can be used from initial diagnosis to surveillance to monitoring metastatic disease if it ever occurs.
Thank you. And I think that's a really great overview, but there's one piece of it that still remains the black box, as they say, and that's really the more computational side. I was wondering, John, if you could let us glance under the hood a little bit, and if you could tell us a little bit about the design of the test and how you choose those mutations.
Absolutely. So great overview, Angel. So when we're thinking about designing that bespoke assay for the individual patient, as Angel mentioned, we start with tumor matched normal whole exome. That gives us an incredible amount of real estate to evaluate bona fide somatic variants. And building on the extensive experience that we have running incredibly high plex plasma assays, starting with our NIPT assays close to a decade ago, we have designed an algorithm that evaluates features of that whole exome signature. So features like clonality are considered, but then we have a really extensive background knowledge base for selecting 16 of those bona fide somatic clonal mutations that play well together, that work together and can be plexed in that multiplex PCR reaction to get really high coverage to enable that 0.01% variant allele fraction detection.
Thank you. And how do you know that it's working well?
Great question. So in the last few years since beginning this Signitera Odyssey, we have worked with a number of really great academic groups and consortiums to evaluate the clinical performance and really generate that clinical evidence that this test is detecting close to 100% of patients at baseline. So if we're looking at metastatic cases pre-treatment, we see greater than 98% of those patients are detected at baseline across the board. And then in other publications, we've really shown that if patients are ctDNA positive by Signitera, that they will almost always recur clinically.
Thank you. And I guess the other tricky piece about a bespoke assay is that with all these static panels, you go through a pretty straightforward validation of specific primers and specific mutations that you're going to be tracking. But here with a bespoke assay, how do you go about validating something that's different for every patient? For every patient, it's a unique set of 16 mutations. What's the process that you managed to come up with there?
Right. We really are venturing into new ground here, right? We have both the tumor match normal test that our test starts with, and as you mentioned, we are using a bespoke primer set for each patient. But we really have reduced this to practice by defining the operand as ctDNA. So we're not validating each individual variant, but we're validating the entirety of the process to detect ctDNA. And we've determined, obviously the measurand, but also every design element from whole exome sequencing through to that plasma sequencing that impacts that ultimate sensitivity and specificity. So all of those design elements, and then we've done analytical validation across a number of tumor types in a number of different settings, everything from MRD detection in the adjuvant setting across different tumor types to therapy monitoring in the IO setting for later stage patients.
Thanks. And is there a track, and you walked us through the process, but is there a track record to show the work that's been done with federal agencies and kind of show their acceptance as well?
So we have announced that we are working on pivotal trials with various pharma partners. We've also announced that we have breakthrough device designations, but those trials have yet to read out. So we don't have FDA approval yet, but we do have FDA breakthrough device designations. We've done a number of pre-subs and risk determination pre-subs as well. We have the test and the kit CE marked in Europe as of last year. And our analytical and clinical validation package has been reviewed by the CMS contractor, and we have a final coverage determination for CRC and a draft coverage determination, which should be finalized this year for immunotherapy monitoring.
Thank you. That's a pretty impressive track record, actually. And Angel, I was wondering if you could walk us through how this translates into the clinical setting and what's the data that you're seeing there for validation.
Sure. So the way that we have clinically validated Signitera was to test for MRD status in patients after completion of curative intent treatment. And so patients presented in these 4 Kaplan-Meier curves completed curative intent treatment, and essentially a patient's test Signitera positive with enough follow-up and no further intervention, these patients' cancers almost always recur. If a patient's test negative, and especially if they remain negative with serial testing, only a few of those patients' cancer will recur. These studies demonstrate that Signitera can identify micrometastatic disease in patients that will experience disease recurrence. These 4 publications also reveal that Signitera can perform better than traditional high-risk factors that we currently use in the clinic to estimate the chance of recurrence, such as lymph node status and histologic grade, which is also how we ultimately identify patients to be enrolled in clinical trials. So this is a more precise and accurate way to identify patients who will actually have events. Now, positive Signitera result without further treatment has a predictive relapse with overall positive predictive value of greater than 98%. And so if we look, take a closer look at data in breast cancer, the retrospective study published in Clinical Cancer Research, so Signitera positive status was shown to be a very strong predictor of clinical relapse without additional therapy. And it's worthwhile noting that not just in this particular cohort, there was a sensitivity of 89%, but also a positive predictive value of 100%, where all patients who tested positive developed a recurrence. But it's also important to view this in the light of a low false positive rate, which can only be determined if you test enough samples serially in patients who do not achieve recurrence. And so in this study, additionally, what was seen was that the ctDNA detection preceded the clinical recurrence with a lead time of 9.5 months.
Thank you. So we started looking into the data already, and I was wondering if we could take this conversation further. And John, is there any data you could share that would maybe show us the difference from static panels? So what's the difference between a tumor-naive approach and a tumor-informed approach that you could tell us about?
Absolutely. So it's really important to keep in mind that Signitera is a fit-for-purpose ctDNA detection assay. We really designed it using the tumor-informed information, so we really know what we're going after in the plasma. And then, as Angel alluded to earlier, we are able to have effective sequencing rates down or up to 100,000x and in some cases even higher. So that gives us really great detection down to 0.01% variant allele fraction. What we have seen in a number of studies is that level of detection is really essential for a number of tumor types. So on this particular slide, we're showing across several different solid tumor types that approximately half of the clinical relapses were first detected by Signitera between 0.01% and 0.1%, which is often well below the sensitivity range of a fixed hybrid capture panel, which are designed to really do tumor profiling and identify potential therapeutic options.
Thanks. And this is the publication. Is there, because I know at this point, Signitera has been used in clinical practice. Could you also maybe go through that broader set of data, which I believe was also even published recently, or at least shown at AACR?
Sure. So on this slide, which was a poster presented at AACR, we looked at across 4,300 different positive samples, and 45% of those were positive at less than 0.01% VAF. And we found that 7.7% of those samples were less than 0.0 or at or less than 0.01% VAF. And you can see that breakdown in the pie chart. It's important to note, we often think in the field about CRC being a high shedding, quote unquote, tumor, but we see really a large number of CRC cases that are actually positive, well below that 0.1% VAF level. So really highlighting the need to have an assay that has that limit of detection to that very, very low VAF level, very few molecules present in a tube of blood.
Thank you. And this being a HER2 positive breast cancer summit, it would probably be great to jump into the breast cancer data specifically. Maybe Angel, you could walk us through some of the findings that we have by even disease setting.
Sure. Yeah, definitely. So now we are sort of getting to see a more clear picture of what does MRD detection look like in patients with breast cancer across the different scenarios, whether it be neoadjuvant, adjuvant, and in the metastatic setting. And so, like John mentioned, we are certainly seeing that there are a significant number of cases where the detection level of ctDNA is lower than that 0.1% VAF, and up to 17% of cases actually have levels detected at even lower, as low as 0.01 and lower than that as well. So, I mean, this is going to be critical when thinking about designing a clinical trial where you want to identify patients who have residual molecular disease and are being identified for patient enrollment, for study enrollment. So being able to have an assay that gets to these levels of sensitivity will allow for recruitment, for quicker recruitment.
Yeah, and what's especially surprising is that with metastatic disease, you would assume that the distribution would be different. You would assume that perhaps you'd be detecting more in the kind of higher ranges, but what we're seeing is that this limit of detection, this lower one, is important across disease settings. It's not as though it's just the neoadjuvant setting. It's really coming across. That's really interesting. And Angel, would you mind telling us a little more about that Signitera approach and why perhaps we're looking at mean tumor molecule instead of variant allele frequency, and if it really impacts your treatment decisions as well?
Sure, definitely. So a couple of things. I think you make a great point when it comes to metastatic HER2 positive breast cancer. Of course, we know that many patients that are in the metastatic setting can have prolonged durable responses and possibly even cure. And so it is critical to be able to identify those patients with an ultrasensitive test that can detect, that can identify levels very low. Because, for example, these 13% of patients, with another assay, they may have identified as ctDNA negative. One would have thought that they would have been one of those exceptional responders. Now, moving into the comparison between MTM and BAF, so yes, remember, the way variant allele frequency is calculated, it takes into account the background cell-free DNA, which can actually fluctuate significantly in patients, whether it be by inflammatory condition, surgery, or even progression of the disease. And so what you see in this particular case, in the blue line, when measuring by variant allele frequency towards the end of treatment, you see that the line sort of flattens out, whereas clearly, when looking at mean tumor molecules per milliliter, the line is clearly trending up, suggesting progression of disease, which is exactly what was happening with the patient. Now, going back to the point of that limit of detection, additionally, if you look at in the green here, you see that, patient appears to be responding well. And so if a limit of detection of a test is at 0.1, one would think that this patient achieved clearance of ctDNA, would otherwise have a great outcome. But with a more sensitive assay like Signitera, you see that actually the patient never achieved clearance, did respond, but then, the peak or the valley was at around 0.01, then subsequently had progression of the disease, which was identified early with this assay.
That is powerful. And Angel, I was wondering if you could also walk us through how Signitera can inform key time points in a clinical trial setting specifically.
Definitely, and I think this is a good time to also highlight and point out, how do we interpret these MRD assays in terms of their performance? And so one can look at that post-surgery single test time point where you're just looking at positive or negative, let's say 30 days after surgery, and how does that predict the risk of recurrence, and what is the sensitivity? But one can also look at this and monitor patients and notice that patients don't always clear their ctDNA, or sometimes they actually do clear their ctDNA, but ultimately have a recurrence. So identifying patients after best curative intent treatment will also allow to identify right patient population who's destined to have a recurrence and unfortunately an event. And then, but one can also design a study where you are doing serial monitoring, and then if at any point during the surveillance the patient has detectable molecular recurrence, then that would be an ideal scenario to enroll a patient in study. And there are many studies that are already enrolling with these different strategies. Yeah.
Yeah, and speaking of the different strategies and clinical trials, there was a publication recently, just at the start of the year, I-SPY data specifically that's focused on breast cancer, and there were definitely HER2 positive patients in that publication of the I-SPY, multiple different studies as well. Could you walk us through that data from the publication?
Yeah. So moving earlier in sort of the clinical journey, or the journey of the patient journey, where we're now in the patient's been diagnosed and receiving neoadjuvant therapy before surgery. So this was a very nice study done in collaboration with the I-SPY2 investigator and Laura Van Veer, where we were able to, sort of as a proof of concept, show that ctDNA monitoring can be accurate in identifying patients that are responding to therapy, as well as an assay that can improve upon prognostication. So in this study, patients were receiving a standard of care neoadjuvant therapy. Now in the platform of I-SPY2, they may have been receiving as well an additional study drug. And so the time points collected here were a baseline after 3 doses of paclitaxel, between the taxane therapy and anthracyclines, and then finally between the anthracycline and before surgery. And so what you see here is the different trends. So first you see that there are patients that clear quite quickly after just 3 doses of paclitaxel. And then you see that there are patients that it requires the whole 12 doses or full cycle of paclitaxel to achieve clearance. And then you have a patient population that we really previously couldn't otherwise see pretty as clearly as we see now. And these are patients that have taxane resistance, but then ultimately clear their ctDNA with anthracycline. And then finally, the patients that are in most great need for something additionally is patients that, despite our best intent treatment, their ctDNA just never clears throughout the course of the neoadjuvant therapy. And so, here, we're identifying patients who are clearly going to relapse without any intervention, but also, patients that are at risk. Those who didn't clear with the taxane but did with AC, those are still patients at risk. Now, on the right-hand side, what we are seeing that we can further stratify, better stratify the way we stratify patients now, right? We normally separate them into those who achieve a pathological complete response and those who don't. And so what we see is that if patients actually achieve clearance of their ctDNA and did not achieve a pathological complete response, that their outcome is quite different. And we have seen similar results that have shown here today with other I-SPY studies as presented in San Antonio Breast Cancer Symposium last year.
That is powerful, and it looks like a great tool to complement PathCR. So that's really impressive. I was wondering if we could take it back to John for a final question around clinical trial work with Signitera. Could you walk us through what are the applications? I know Angel walked us through some of the critical time points, but if you have a high-level overview of all of the applications for Signitera in clinical trials, and maybe if you could give us a taste of new data to come in the future, that would really be great.
Absolutely. It's really an exciting time to be involved in this field, and we're really seeing quite innovative trials in partnerships with our pharma and biotech collaborators. So as we've alluded to previously, I think one of the really dreams for an assay like this is to be used in clinical trials as a surrogate endpoint. So we are building that case now. So we're seeing a lot of use as a secondary or exploratory endpoint, and increasingly looking at a co-primary endpoint. Still work to be done there. So using that ctDNA clearance as surrogacy. we're seeing some really exciting trials, and some of these have been press released, including the Roche and Intech InVigor-011 trial, which is enriching for patients who are likely to need additional therapy because of residual disease in the adjuvant setting. We're seeing a number of these trial designs across different solid tumor types. Earlier on in drug development, platform type studies have really been exciting. So getting that early information of which combinations or which tumor types in a basket type study are really set apart or winning or not winning, so that drug developers can move on to the most impactful regimens quicker. Treating on molecular relapse is really an ability to define new patient populations. So as treating as early as you can see the molecular evidence of disease coming back, as opposed to waiting for more traditional outputs of relapse. And then in immuno-oncology, we published last year and now have the Medicare draft coverage determination, but we're also working with pharma partners in trials where there can be escalation or de-escalation strategies to really ultimately improve patient outcomes with the addition or subtraction of IO agents. And then on the research side, we are able to use those immortalized genomic libraries from plasma to further interrogate neoantigens, resistance mutations, or other subclonal type mutations that aren't captured in the classic Signitera assay, so we can get a better sense of that biology in specific cases.
Well, no wonder you're staying so busy with all of these wonderful use cases. And for folks listening to the call, hot off the press, InVigor-010 data has just been published in Nature Cancer, so make sure to take a look. There's some amazing supplemental graphs and materials. But to close us off on this conversation, all of this great data coming up in the future, Angel, what does it mean for patients?
Yeah, absolutely. I think this is, there's a paradigm shift going on when it comes to identifying the right patients, but it's not just about identifying the right patients who molecularly we can identify are going to have clinical recurrence, but it's also about matching them with the right drug. And I think when it comes to HER2 positive, not just breast cancer, but all cancers, I think the future is quite bright. And it's to be able to do this MRD adaptive approach where you can, try, one medicine and then monitor, right, in the adjuvant setting to see if it's actually working in a way that we could never treat and monitor before. So the future is quite bright for patients with HER2 positive breast cancer.
Thank you so much.